Dear audience, my name is Mariangela Pellegrini. I'm the Educational and Patient Program Manager for the European Reference Network on Rare Hematological Disease, EuroBloodNet. And it's my great pleasure to welcome you on behalf of the whole ERN to this session of EuroBloodNet Thursday webinars. As you may know, the aim of this educational activity is promoting the interest of very innovative topics in order to stress among health professionals the advance in the field of rare hematological disease. So today we are going to assist to a lecture on newborn screening for sickle cell disease in Europe, recommendations. So, dear audience, please welcome with me the speaker of today's session, Dr. Raffaella Colombatti. She is pediatric hematologist oncologist at the Pediatric Hematology Oncology Unit of Azienda Ospedaliera University of Padova in Italy. Her main field of interest are rare cell disorder, especially sickle cell disease. She has contributed in creating the Sickle Cell Veneto Region Reference Center in Padua, and he's clinical coordinator of the local universal newborn screening program. She's in charge of the General Hematology Anemia Clinic. In the past years, she has been involved in clinical research on sickle cell disease vasculopathy, cerebral and neurocognitive abnormality and brain function. Dr. Colombatti is also interested in child health in Africa, and he's leading several projects in Guinea-Bissau, West Africa, in the field of hematology and infectious disorder. So please, Dr. Colombatti, the floor is to you.
Thank you, Mariangela, for this kind and comprehensive introduction. So the topic that I've been asked to talk about today is newborn screening for sickle cell in Europe, with the focus on European recommendations. So the first thing we're going to see is why is it important to talk about recommendations. So a brief background on sickle cell disease, which is a rare blood disorder, a disorder of the red blood cells that were discovered in 1910 in Chicago from a student coming from Grenada, West Indies, who had hemolysis and the sickle red-shaped cells in the blood smear. Since that time, sickle cell disease became the first molecular disease to be discovered, a disease of hemoglobin. It was discovered that sickle cell disease trait is protective against malaria. That's why sickle cell disease is mostly prevalent in areas where malaria was a leading cause of death or is still a leading cause of death. In the 1970s of the past century, the United States were the first nation to establish a national sickle cell disease program involving screening, counseling, and awareness raising among the public. And after that, hydroxyurea was discovered. So it's a genetic disorder, a recessive disorder of the red blood cells, and it shows extreme phenotypic variability, but it's also a systemic disorder. What is important, and it has an impact on diagnosis, is that there is the homozygous sickle cell disease genotype, but also the double heterozygous genotypes. And all these needs to be identified in order to have a successful screening program. Sickle cell disease has also been defined in the past decades as a public health issue by the World Health Organization and the United Nations. Now, being recognized as a public health problem, of course, has more strength when a disease needs to be considered for a public newborn screening program. So only diseases that are relevant for the population and for which an early diagnosis has an impact on survival should be included in newborn screening program. So for sickle cell disease in 2006, the World Health Organization, and in 2008, the General Assembly of the United Nations recognized it as a public health problems for which public health systems need to provide comprehensive national integrated programs for prevention and management. And in fact, we can see that 7% of the world population is a carrier of a pathogenic hemoglobin variant, and more than 300,000 children are born every year with sickle cell disease. From the numbers that you see reported on the slide, of course, the majority are estimated to be born in Africa. I say estimated because currently there are no comprehensive registries or databases in Africa. So we only have pilot newborn screening or pilot database that can give us estimates. Unfortunately, also the data collection in other parts of the world is not exactly the same and is not comprehensive for the population. What happened that raised the need for newborn screening in Europe in the past decades? The global increase of migrants with the sickle cell disease gene. In this picture taken from a recent paper in The Lancet by Fred Peel and colleagues, you can see that in the past 50 years, there has been a global increase of migration trends, but specifically migrants with the sickle cell gene migrated more than migrants without the sickle cell gene. And this migration brought to Europe migrants coming from Africa and the Middle East or South America, so increasing the carriers of the sickle cell gene in the European population, especially in Western European countries. What is sickle cell disease? We said it's a disease of the red blood cells, and it causes hemolytic anemia, vaso-occlusion, and vasculopathy. And therefore, it's a systemic disease because these aspects can hit all the organs in the body. And in fact, in the 70s, when the national program started after the publication of the Sickle Cell Act in the United States, life expectancy for people with sickle cell disease was only 7 years of age, while it's now 55, data from last year. So why did we have this improvement in survival? We can see that children with sickle cell disease died before age 5 from infection, splenic sequestration, cerebral vascular accidents. So the life expectancy was low due to preventable complications. And in fact, following up the timeline that we started to see a few slides ago, advances in healthcare in sickle cell disease demonstrated that penicillin prophylaxis, stroke prevention, penicillin prophylaxis starting at 2 months of age, stroke prevention starting at 2 years of age with blood transfusion in case of high risk, and early preventive measures have surely increased survival in sickle cell disease. And in fact, newborn screening allowing early diagnosis can ensure that children who are diagnosed at birth can have immediate application of all preventive measures that improve survival. So sickle cell disease matches the definition of a disease that it's present in a population for which an early diagnosis reduces mortality. And in fact, this was one of the first papers that in the United States demonstrated the benefit of newborn screening in reduction of mortality and increased survival, and it clearly demonstrated that those children that were diagnosed through newborn screening had a higher survival. These data were replicated in pilot screening programs in Europe in the following years. And this led to the fact that sickle cell disease is now, sickle cell disease newborn screening program have been implemented more in European countries, even though sickle cell disease in Europe is still a rare disease. And you can see on the left-hand side of the screen, data from newborn screening programs coming from several European countries. And you can see on the right-hand side of the screen, data coming from pilot programs in some African countries where recently, we have recently published data, and you can see the massive difference ranging from 0.47 per 1,000 births in the UK, which together with France is one of the European countries in which we have the highest number of births of children with sickle cell disease. It's a huge difference compared to Ghana, when you have, for example, 18 newborns with sickle cell disease over 1,000 births. So how did we reach an agreement on recommendation for newborn screening for sickle cell disease in Europe? Of course, several countries have their own recommendation in their own language, the Italian, the Spanish, the UK, the French, the Belgian, and the German. But again, it was important to have a consensus, an agreement on newborn screening across Europe. And this was done through a consensus conference, which was conducted in 2018. And there was the need, since sickle cell disease was an increasing global health problems also in Europe, and that was challenging the European healthcare system, there was the need to have a more common approach, not only in defining the need for a newborn screening or not for sickle cell disease, but also which kind of methodologies and policies for newborn screening could be recommended in Europe. A two-day pan-European consensus conference was held in 2017. Then the recommendations were published in 2018. And more than 50 sickle cell disease experts from 13 European countries participated in the conference. And it's important to notice that also patients' representatives participated in the conference and gave their opinion on patients' perspective. And we will briefly review together today which are the consensus recommendations. But first of all, I want to share with you the methodology of the consensus, because it's very important to see how, from a European perspective, the point of view of different countries and different healthcare systems, although they're very similar but not exactly the same, can find a common solution. So 4 months before the conference, clinical and laboratory experts in the field of sickle cell disease in European countries were invited to participate. Experts were selected by a steering committee on the basis of their publications or presentation at scientific meetings. They were joined by representatives from national scientific societies, national sickle cell disease reference centers, or national newborn screening programs if they were available. There was a standardized form for the presentation of each country's national data on newborn screening that was sent to the speakers 1 month in advance of the conference. And also the committee drafted a list of questions for the consensus discussion. On the first day of the conference, key topics in epidemiology, screening, and newborn screening were reviewed, and representatives from 12 European countries reported data from their own countries. And on the second day, the consensus questions were discussed and experiences on newborn screening outside Europe were explored. And the discussion was moderated by an independent non-European specialist assisted by a patient representative. So what was addressed? The overview on epidemiology of sickle cell disease in Europe and worldwide, the examples of already established newborn screening programs like the UK and France, the comprehensive care model of sickle cell disease in UK and France, a review of standard and emerging technologies for the diagnosis of sickle cell disease like HPLC, molecular biology, mass spectrometry, and point-of-care testing were reviewed, and also the current situation of sickle cell disease and newborn screening in every European country. Patients' associations' perspective were also listened to, and then the consensus questions were read and discussed, and I'll go briefly through them with you. Do you agree that the number of children born with sickle cell disease is currently increasing? What are the target diseases in newborn screening program for hemoglobinopathies? What is the significance of thalassemia? what is the justification of a newborn screening for sickle cell disease and thalassemia? Which countries or regions or cities should screen? Who should be screened? Should the screening be universal or targeted or selected? How to handle carriers? Which methods are recommended or acceptable? What is the recommended procedure after a positive screening results? And which blood samples are recommended acceptable for screening? What are the pitfalls? Which false negative and which false positive rates are acceptable? And are these recommendations valid for all high-resource countries, or is there any dependency on specific local characteristics? So you can see that these questions not only address epidemiology or laboratory issues, but also what happened to the sample and to the patient after a diagnosis was made, and also how to report positive results. So all the aspects of the entire process of newborn screening, diagnosis, communication, and enrollment in a healthcare program were addressed by the group, which was, as you can see, more than 50 experts coming from 13 European countries. And let's go briefly through the consensus reached that can serve as a basis to widen a newborn screening in those countries that still do not have universal nationwide newborn screening program. So it was agreed that in Europe, the burden of sickle cell disease has increased and it will continue to increase. It is desirable that all European patients with sickle cell disease are enrolled onto registry with standardized data collection and coordinated follow-up. It was agreed that targeted disease of a newborn screening program for hemoglobinopathies is sickle cell disease, including all genotypes, but not beta thalassemia. And this was because the early diagnosis before 2 months of age is not so crucial in beta thalassemia. Early diagnosis by newborn screening together with all the preventive measures reduces mobility and mortality for sickle cell disease in childhood. The implementation of a national newborn screening for sickle cell disease should be informed by a review of national epidemiological data on sickle cell disease in that country, but should not be based solely on threshold birth prevalence. If not available, national data should be collected. A newborn screening program is not enough. Children need to be diagnosed, but also taken in care. So a national newborn screening program needs to go alongside the national disease management strategy. The panel recommended universal newborn screening for sickle cell disease in all countries participating in the conference, and they were all Western European countries, which experienced the highest wave of immigration in the past decades. Targeted screening based on ethnic origin is not recommended because of the higher risk of failure to identify an affected newborn. So the panel recommended universal screening, which is not yet achieved in several European countries. And in countries where national newborn screening for sickle cell disease is not implemented, it was suggested that an interim policy should be agreed for testing at-risk newborn on a case-by-case basis. Another issue that caused a lengthy discussion was the fact to communicate the carrier state. So sickle cell disease is a genetic condition, but Europe has a history of stigma due to genetics and ethnicity. So in some European countries like Germany or the Netherlands, it's not allowed to communicate the carrier state due to fear of racial discrimination. So it's still a legal issue that is an aftermath of World War II. So it was written in the consensus that further discussions in these countries with legal and ethical experts should be started in order to also communicate the carrier state. And this is still ongoing in these countries. Regarding the techniques used, they're not all similar. High performance liquid chromatography, capillary electrophoresis, isoelectric focusing, and mass spectrometries are the appropriate methods, but new methods are currently being tested and should prove to be specific and sensitive as the gold standards before being implemented on larger scales. There were also several specifics to guide data interpretation and retesting in case of a positive sample, whether the retesting should be performed on the same sample or on a different sample, recalling the family. And it was left to the single nation policy to choose the best according to the organization of the healthcare system. And in the end, the panel recommended universal newborn screening in all countries participating in the conference, so Western European countries, collection of data on clinical outcomes through setting up of registries, and development of shared clinical protocols for comprehensive care of all affected newborn. Raising public awareness about sickle cell disease was also recommended, as well focused education about the condition for all healthcare workers, professionals, managers, and commissions of health systems. So currently, that was a great achievement to have reached a consensus in Europe. Currently, there are still different approaches. There are some national programs, some regional programs, some pilot programs. Unfortunately, not yet all the countries have a national newborn screening program that is similar everywhere. Italy, for example, does not. Still, there are some countries that use universal, but other areas use targeted approach. And there are different techniques. The UK has moved to mass spectrometry, while other countries still use HPLC. So it depends on the possibility of partnering the hemoglobinopathy screening program with the metabolic disease screening program according to the setting. If somebody of you wants to, deepen all the European perspective, this was a special issue published after the consensus conference on newborn screening for sickle cell disease and hemoglobinopathies in Europe, but also with insights into other countries' experience, for example, Brazil or the United States. And thank you for listening to this brief overview on the recommendation for sickle cell disease screening in Europe.
Thank you very much, Dr. Colombatti, for this excellent presentation. Very comprehensive from geopolitical point of view to clinical. So I think this will really raise a good debate. So, well, I don't need to say, please write the questions because we have already, but I encourage the audience to write the questions in the chat. So the first question, hi everyone. Based on current migration of those from target areas, considering most to be of childbearing age, what programs could be put in place to screen for sickle cell trait in the efforts of gathering data on SCT prevalence and possible childbearing of newborn infants with sickle cell disease?
Yes, there is a continuous migration from areas of the world to Europe. And in fact, looking at the data coming from the numbers, the figures coming from various European countries in the past 2 or 3 years, they coming from the Middle East, but also from Pakistan, Afghanistan, Northern Africa, Eastern and Western Africa. For example, many migrants come from West Africa in Italy, for example. there is not routine screening programs upon arrival of the migrants. So this is still an open issue that several bodies and scientific society are pushing for, to use the point of care testing that are now more accessible and affordable because they're rapid tests and the cost is going down. We have, I think, now the choice of 5-6 rapid tests. So one hypothesis is to screen the migrants from area of with high prevalence upon arrival to Europe. And the other two possibilities are the screening, the antenatal screening, so widening the offer to be screened to pregnant women and their partners. And again, this is well done in some countries, for example, the UK, but not yet widespread in other countries. And then, of course, the other issue is newborn screening. So a push towards a widespread enrollment in newborn screening everywhere in Europe. All these three strategies could help us gain more information on the exact prevalence of sickle cell disease and sickle cell disease trait in Europe. Although, as I mentioned, in some European countries is not allowed to communicate or record the carrier state. I hope I'd answered the question. I can see another one.
Yes. So I would like to ask Dr. Colombatti, how is the strategy in Italy about carriers? Who is in charge of communicating the carrier status? Is it made by specialists or general doctors? Is there a record in the clinical history of the child? Thank you very much.
So I must specify that Italy does not have a national newborn screening program. So if you are asking how the carrier state is communicated in the framework of newborn screening programs, Italy has some pilot screening programs ongoing and some regional screening programs ongoing. The carrier status is generally communicated by the pediatrician or the pediatric hematologist in these pilot programs. And in general, when a child is diagnosed with the carrier state or the sickle cell disease state, it's made by the pediatric hematologist, to whom the child is always referred in case of explanation on hematological or laboratory values. And it is, yes, recorded in the clinical history of the child, although we do not have like a sickle cell disease card nationally. And therefore, it's recorded in the letters given to the family, or for example, in our center, in a booklet about sickle cell disease that we give to the families, but there is no common nationwide health record or tracker of the sickle cell disease carrier status.
Thank you. So I go to the next question. Thanks for the presentation. In your opinion, what degree of homogeneity in the screening programs do we currently have in Europe?
So still there are not so homogeneous, because as I said, in the United Kingdom, for example, it's universal newborn screening, and then the children are all enrolled in the National Hemoglobinopathy Registry. In France, it's targeted in some areas and universal in the Paris area. In Germany, it should start, it was after several successful pilots, it was approved on a nationwide scale, a universal and a newborn screen, and it's going to start, or it's just started. And so it's not universal, national in all countries, although the recommendations are in that sense. The tests are also not all homogeneous, because some centers, some countries use HPLC and isoelectric focusing, others use HPLC and molecular biology, others use mass spectrometry. So not everything is the same, But again, not everything needs to be the same because the settings are different.
Thank you very much. As newborn screening is currently ongoing in some of the European countries, is there any specific data on statistics as a result from the screening program in those countries?
Yes, so some of the countries have national registries like Spain or the UK or Germany. And there are recent publications in the past 2 years of data of the outcomes of the newborn screening programs, but also the benefits on survival in children in these countries after the implementation of the newborn screening. And so the reduction of mortality, which still is not zero, and so still we're not allowing all the children with sickle cell disease to survive to teenager age or adulthood. And so, yes, they are freely accessible on the web, some of the results of the registries, other are in the form of scientific publications in English. And those can be reached through Google or PubMed, so can be easily accessed.
Thank you. So I read, hi, I'm a patient representative for Portugal, UK, and also part of the European Sickle Cell Federation. In some countries, it seems that sickle cell disease is part of the universal screening program via the heel prick test, but only as a part of an extended paid for tests around 200 euros. This will probably reduce dramatically the number of tests performed. So is this situation under your radar? What alternatives are there and what can be done to make it real, universal, for instance, free and for all?
Okay, this comment is really surprising because as far as I know and what came out from the consensus discussion is that that sickle cell disease is the newborn screening is free because newborn screening is free everywhere. Otherwise, there is a discrimination for the poorest families, and a universal newborn screening program cannot discriminate whether on ethnicity, religions, origin of the patients, and economic status. So this is surprising. And maybe, Mariangela, we can catch this and follow up further where this information comes from, because according to what we know as healthcare professional, it is free. And we can further deeply look into this in case this information is confirmed for certain settings, I think.
Sure, definitely. Do you see any primary prevention from newborn screening in the sense that affected births are prevented?
So this is the antenatal screening, and I know that in the United Kingdom is pretty well established, and there is prevention in the sense that the possibility to terminate the pregnancy is offered if the diagnosis is made from an antenatal setting. I'm not aware of data from this in published, only the results of newborn screening programs. My personal experience with our patients is that they are not so willingly, do not like willingly to do antenatal if they are not convinced to do an abortion. So they don't rely on antenatal screening, and they prefer to wait and do the newborn screening. But again, I'm not aware of results being published specifically in Europe on this topic.
Okay, thank you. So last question. Can EuroBloodNet follow up on genetic counseling for parents as a result of feedback from the newborn screening program in Europe. Example is Germany. There is a huge lack of genetic counseling as a follow-up service. What plans will be put in place?
I think this is a huge topic, but since many newborn screening programs in Europe, except the United Kingdom and France that have a longer history, are very recent, like Spain and Germany, for example, I think it takes time to build an experience and all the network to do this. If there are still lacks in this, there's still gaps in this sense, we can surely promote a discussion among the national representatives and the sickle cell disease experts group in EuroBloodNet, but I think it might be also due to the fact that they are more recent programs. So probably waiting a bit, but again, bringing it to on the discussion table with the experts might be a good thing that can be done in the appropriate tables, Mariangela.
Yes, I agree. Also because it is a national political issue, so we just could provide like evidence at policy level.
I see one last question. How can patient organizations and advocates support the newborn screening campaign? So again, I think that, for example, next month is the month of the 19th of June, the Sickle Cell Disease Day. If in the interviews that patient organization release in their countries or in their websites or in other rare disease website, they push for the need of newborn screening in those countries that still don't have universal newborn screening, it might be a great asset for physicians that in their regional areas or local areas or in their countries, according to the characteristics of the healthcare system in those countries, can usually be a stimulus, advocacy that might help the clinician push a newborn screening program forward, because of course in the end it's money is needed for this, but if the patient voice is heard, of course money can be put also in this in various areas. So I suggest that in the next months, seizing the opportunity of the 19th of June, patient organization talk about newborn screening, and newborn screening as the first step of taking care of patient with sickle cell disease, because it's an early diagnosis. I think it can be very important and performed very soon, so next month.
Thank both of you, so the audience, for this great debate, and Dr. Colombatti for the presentation and the debate too.